Welcome to the download. This is MiHIN's monthly webinar that dives into content at the intersection of healthcare and technology. My name is Katrina Gagne. I am the outreach specialist at MiHIN and your facilitator for today's download. I'm joined by Tracy Webb, MiHIN's outreach manager, who will be our Webex Chat moderator today. Before we get started, I just wanted to go over some logistics. This session is being recorded and will be available on MiHIN's website after today's meeting, as will the slide deck that we're sharing today. All attendees have been muted upon entry. We are very pleased to have a large group join us for this webinar today. So to ensure good audio, please remain muted throughout. We encourage your participation by using the Webex Chat feature. Feel free to ask questions and make comments via chat anytime throughout the presentation. We definitely want to hear from you. Once our presenters are finished with their segment, they will be responding to questions through the chat. But if they don't get to answer them via chat because of time, Tracy will bring them up towards the end of the webinar when we will have some time scheduled for Q&A. If we don't get to answer all of the questions today, we're going to close the loop for you all with an email to all attendees that will have those questions answered. I also want to point out that the Webex chat is located on the right side of your screen. Please be sure to notice the drop-down menu with options for who can view your message. So before we get started, I also want to take a little bit of time to provide a little bit of background about MiHIN. We are a network for sharing health information statewide for Michigan. Our mission is to continuously improve healthcare quality, efficiency, and patient safety by promoting secure electronic exchange of health information. Our success comes from 5 focus areas of our work. We convene people, our stakeholders, in order to listen, learn, and get feedback on functional solutions. We partner with stakeholders and champion statewide use cases or data sharing scenarios that get various types of healthcare data flowing from providers to the health information network, then out to all parties who have an active care relationship. We operate as the shared services among the participants in the health information network. That includes behind the scenes infrastructure for network participants to easily share information across the state. We provide tools such as My Gateway, Viper, Direct Secure Messaging, and Transitions of Care Viewer to support daily workflow and coordination. And finally, we provide reports, conformance standards for the data, and analytics from data lakes and the longitudinal record. So this is what the rest of our agenda is going to look like today. Next up, we have Shreya Patel, who is MiHIN's Chief Policy and Privacy Officer. She's going to share some background about the Centers for Medicare and Medicaid's final interoperability rule, specifically as it relates to conditions of participation requirements for ADT messages, which MiHIN has been closely tracking. Then Kim Batchelder, Senior Product Marketing Manager, and Crystal Schramm, Assistant Product Manager, will provide an update on work MiHIN's doing to address the exchange of behavioral health ADTs and the current development of the e-consent product. Then we're going to have some time for Q&A, so please be sure to send your questions via chat. And finally, I'll wrap up with a few announcements. So without further ado, I'm going to hand it over to Shreya.
Thanks, Katrina. So as Katrina mentioned, this is Shreya Patel. I'm the Chief Policy and Privacy Officer at MiHIN. And today I'm going to be discussing the Center for Medicare and Medicaid Services, or CMS, conditions of participation, or COP, for admissions, discharge, and transfer notifications, or what as we like to call them, ADP messages. So I know these three acronyms are confusing to keep track of, so I've listed them on this slide, but please feel free to ask questions in the chat box if things begin to get a little too difficult, and we can answer some of those questions as we go. So as we discussed in the written portion of the download that kind of accompanies our monthly webinar, COPs are federal regulations which typically come out of CMS, and they require specific healthcare facilities to comply with requirements in order for them to receive Medicare or Medicaid dollars. So if you want to look at it from a really high level, what typically will happen is Congress will release a law giving a federal agency like CMS the ability to write regulations for a particular area. CMS will then release a regulation that will place specific requirements on healthcare entities, but the best way for those entities to be motivated to comply is to tie that requirement to Medicare and Medicaid funding. And that's really where the COPs ultimately come in and why they're going to be such a big deal. Now, the ones that we're going to be discussing today address one specific part of the CMS final rule that came out earlier this year, and that is a requirement for hospitals to send ADP messages to established providers of a patient. Next slide. So these COPs were released earlier this year, and since that time, MiHIN has been active in trying to unpack the content in them. So as part of our analysis, we read through the requirements and realized that this would have a fairly significant impact on the HIE space. So from there, we compared them to MiHIN's own ADP use case. We reviewed any guidance from CMS, if there was any ambiguity in the language or anything like that. We determined how this would affect our hospital stakeholders and brainstormed on how we could support them in meeting those requirements. And then we also went one step further to further examine how this may affect interstate exchange of ADP messages. And we consulted with other entities on a national basis to determine how others were understanding the requirements to just ensure that we weren't missing the mark in our own analysis. Next slide. Now, over these next few slides, I'm going to break down the key information everyone should know from the COPs. And while the exact language is going to be on the slide, I'm going to try and summarize in order to make this a little bit easier to understand. So the first basic question is, who do the COPs apply to? And for the ADP requirement, it is only going to apply to hospitals, psychiatric hospitals, and critical access hospitals for now. What's interesting, though, is that CMS went even further in their rule to say that the requirement's only going to be imposed on hospitals who actually have the capacity to generate the basic patient, personal, or demographic information needed for electronic event notifications. So again, that's just something to keep in mind when trying to determine if this is going to apply to you or not. Now, if you are a hospital that is going to be subject to the COPs, you have to meet the requirements that are set out in them. And that includes being fully operational and compliant with federal rules for health information sharing, being able to use the content exchange standard necessary for sharing, being able to send minimum patient information, and I'm going to go over what that minimum patient information is in the next slide. And then lastly, being able to send notifications through an intermediary. And anytime you hear the word intermediary, think of someone like a HIE or an HIN that ultimately facilitates exchange of health information to a wide range of recipients on a hospital's behalf. Next slide. So as I mentioned before, minimum patient information must be sent, and that's going to include a patient's basic personal or demographic information, the name of the sending institution, and the patient's diagnosis, so long as the sharing of that diagnosis is not restricted by state or federal law. Now, when it comes to how information must be sent, COPs don't go into great detail here. They merely say that the hospital system must either be able to send directly or through an intermediary. And again, when you're thinking of an intermediary, think of an HIE or an HIN. But really, the second part of this requirement becomes important because they begin to go into who should receive the notification as well. And on that component, they say entities will receive the notification if they're receiving it for treatment, care coordination, or quality. 2, for entities that have an established care relationship with the patient. And 3, for entities that the hospital has a reasonable certainty that they can receive the message in the first place. Next slide. And just to expand a bit more on that last point of to whom the ADP messages should be sent, the COPs state that a hospital only needs to send if there's a reasonable certainty of receipt, but they do need to send the notification to those who are in a way entitled to receive the message. So this actually places an affirmative duty on the hospital to ensure that their system sends the notification to the patient's PCP or primary care provider, the patient's primary care practice group, or any other practitioner, practice group, or entity identified by the patient as someone who needs to have the information. Now, I am going to pause on this slide just for a minute because this requirement has opened up a lot of questions on interstate exchange of ADPs, or what to do if the recipient needs the ADP sent to a different state or even in a different format. And the key thing to keep in mind here is that the standard for hospitals to send these ADP messages is reasonable effort. So this is not going to place a burden on hospitals to begin sharing with PCPs that refuse to do basic things like legally onboard or that require messages to be sent in an unduly burdensome format. And that's not to say that hospitals can't accommodate those requests if they would like to, but they are by no means saying that these rules are so stringent that hospitals are going to need to go above and beyond their capabilities to meet every single request posed. And I know that it seems like this interpretation kind of goes against the substance of the rule, but we have had many conversations externally on this where organizations are agreeing that while they will do whatever they can to comply with reasonable requests, in a healthcare climate where TEFCA and interstate exchange hasn't been fully realized, and where we do want to share with the adequate privacy and security measures present for interstate exchange, organizations don't have to, preemptively agree to a yes to every single request every single time. And just to clarify, this interpretation is not going to be construed as information blocking as much as it is going to be a limitation on what hospitals and HIEs can do today. Next slide. So before we wrap things up, I wanted to bring it back to how these requirements align with our use case and how we can best serve the hospital community. So when compared to MiHIN's ADP use case, we not only meet, but we go above and beyond all the requirements in the COPs. And as an entity that has put into place a very successful statewide ADP use case, we're really happy to serve as leaders in the space and to further shed light on how others can best work to begin sharing this information. Another way that MiHIN is able to serve its stakeholders is going to be through connection itself. So the COPs stated many times in their guidance that participation in an intermediary like an HIE or an HIN who is connected to a wide range of participants points to compliance with the COPs because those HINs or HIEs can accommodate the sharing of ADP messages on behalf of their hospital community. And that's exactly what we see happening within the state of Michigan. And then lastly, MiHIN has and will always continue to be a resource for its stakeholders and to all of you that tune into the download every month. I know that this presentation kind of unpacks some of the surface level content, but if any of you would like to go into detail on how these requirements work or how some of this ambiguity is being addressed across the country, please do feel free to either reach out to myself or anyone on the MiHIN team. And I think that we'd be happy to set up more time either at the next download meeting or some individual time for us to really unpack some of those other components. So with that, I am going to wrap up my presentation. We're going to hold questions until the end of all of the presentations. So if you do have questions, feel free to start asking them in the chat function, and we can either answer them throughout the second portion or at the very end. But I am going to pass it over to Crystal Schramm and Kim Batchelder to talk a little bit about behavioral health ADPs and some e-consent project updates.
Thank you, Shreya. Hi, my name is Crystal Schramm, and I'm an assistant product manager at MiHIN. and I'm going to be discussing the behavioral health ADT use case with you, and Kim will also talk about the e-consent use case and product updates after I present. Next slide, please. So before I get into the policy and kind of how we're approaching the use case, I wanted to just take this moment to really refresh everyone on the terminology that go into behavioral health and mental health, because I think so many times in healthcare they're used anonymously, but really they're two completely different things. I think it's important to remember that behavioral health is really that inclusive blanket term, umbrella term that mental health kind of falls underneath. And it really is the promotion of mental health, the resilience and well-being, and the treatment of mental and substance use disorders. So it really is an umbrella term. And then underneath that one falls mental health, which is more specific. It includes our emotional, psychological, and social well-being, and it's integral and essential component of healthcare for patients. And then SUD, or substance use disorder, is using drugs in a way that harm you or that lead you to harm others. It can range from mild to severe. It's sometimes called addiction, and it's the actual, it really can be a diagnosis that can fall underneath, mental health. And then it also is more specific for Part 2 facilities. And then getting into SBI, that's more generic, but it really means specially protected information, and it's health information that can be authorized to be used for the purpose of coordinating an individual's medical care amongst the individual's healthcare providers. And it's really relevant because at certain times, healthcare providers may need to share behavioral health and mental health information to enhance the patient treatment of something like a substance use disorder and to ensure the health and safety of the patient or others. Next slide, please. So the Behavioral Health ADT work group was formed in Michigan by the CIO Forum, and it was formed to develop the guidelines that were to facilitate the behavioral health ADT submission to MiHIN. Now, I know Shreya really talked about the national perspective of ADTs. My presentation is going to focus on more the Michigan side because we're talking about the policies and regulations that go behind how we can share this behavioral health data. And according to the recommendations from the CIO white paper, information can flow from a community mental health organization through MiHIN and then to the participating providers like primary care, hospitals, or other behavioral health organizations. And it's really important because this would allow the sharing of information and other behavioral health and physical health treatment that the providers need to see for care coordination to the active care team. It is important to note that for the substance use disorder piece under 42 CFR Part 2, that there are stricter requirements outlined, and that does require patient consent before Part 2 information can be sent out. Next slide, please. So MiHIN is really looking at a phased approach on how we are able to start sharing behavioral health ADTs. So number one, what does this mean for your organization? If you are not a Part 2 facility, you can start sharing ADTs, sending and receiving with MiHIN right now. Many organizations that are community mental health organizations already are receiving ADTs from MiHIN, but they can also start sending. And it doesn't need to be under a separate use case. They can use the statewide ADT use case that you could already be signed on to now. And if you're not already doing that, you can sign on to our statewide ADT use case that is active and start sharing those ADTs now. But the next steps then incorporate the Part 2 facilities and the consent. So really in this slide, steps 2 and 3 they kind of go together, because what it means is that for organizations that require a consent to share specially protected information, we've begun creating the Behavioral Health SPI ADT use case. Long name, lots of acronyms, but what that means is that that's going to enable the sharing for Part 2 facilities and specially protected information. That's going to partner with our e-consent use case, which will enable the specially protected ADT data to flow to the active care team members that have a consent registered in our statewide e-consent database. So I just wanted to separate them out here to show that the first one, that's related to our statewide ADT use case that's active now. And then steps 2 and 3 will be 2 separate use cases that are currently being developed right now. Next slide, please. So as I stated, non-Part 2 facilities who want to get onboarded can now sign on to the statewide ADT use case and begin sending and receiving ADTs. Some of you who are already receiving the ADTs might have you would already have a transport mechanism set up. So you either need to decide if you want to use the same transport mechanism to also send the ADTs, or if you want a different one, then it might take a little bit longer to get that transport mechanism established. It would just be more mapping and it would take longer to do that, but you just have to keep in mind what your organization wants to do. And again, the use case exhibit covers both senders and receivers. Next slide, please. So currently, for the Part 2 facilities, for this use case, we are updating and developing the use case implementation guide. Someone just posed a question at Cheryl, I believe, in the chat, the difference between a non-Part 2 and a Part 2 facility. Part 2 facilities, and I don't know if Kim Batchelder, if you want to ring in on this, but they share specially protected information throughout the state of Michigan. So there's certain information that they have for patients, and I'm gonna let Kim kind of go into that a little bit more. Kim, can you chime in?
Yeah, sure. So Part 2 facilities are defined in 42 CFR Part 2, which is a federal regulation that defines like substance abuse, especially protected information facilities, and therefore requires consent to share that information. And at a high level summary, that's what a Part 2 facility is. It's related to that federal regulation of CFR 42 Part 2.
Perfect. Thank you, Kim. So as Kim said, for the Part 2 facilities, they will be included in this SBI ADT use case. And in the use case implementation guide, we're going to explain how organizations can generate their ADTs to populate the messages that contain that specially protected information data. And the way we're approaching it right now is MiHIN will receive the ADTs, and then the message will be parsed looking for the SBI tags in the Z segment. So that's a lot of technical speak, but basically when the message comes through, MiHIN is going to check the message and say, and look and see if it has special information, and if it does, it's gonna stop that right there, and then it's gonna say, okay, does the organization that's going to receive this information, do they have consent to receive it, and does the patient that the information is tied to, they're sending it, did they consent for their information to be sent? So the consent's kind of two pieces, but that's really what that's saying. Next slide, please. This figure is to show the future state after these, the behavioral health ADT use case and e-consent use case are applied for those Part 2 facilities. And what it's showing is the path of an ADT notification from that psychiatric facility or treatment center, and then going through MiHIN, and then going to those other user facilities. So in this data flow, the patient, Jorge, is admitted to or transferred or discharged from that facility. The ADT notification is created by the facility's EHR system. The EHR system then sends the ADT to MiHIN. MiHIN looks at the ADT message, determines if it contains specially protected information. So that's the first step. Then the second step is, okay, is there patient consent to share the information? And then MiHIN finds the patient and the providers on the patient's care team using the active care relationship service. And then in the midst of that, MiHIN is also determining which providers have patient consent to receive the information. Once it does that, MiHIN looks up each provider in the health directory to determine the destination and the transport method by which each provider and facility wants to receive that electronic ADT notification. So What this does is it results in improved care coordination between all of the behavioral health providers and physical health providers on the patient's care team, who can now share combined information about the patient's behavioral and physical health. Next slide, please. So going forward, what we're doing is we're looking at the future. So that was kind of what the data flow I just walked through is what the implementation guide we're developing now is going to do. That's what, when you sign on to that, that's what you'll be able to do. But going forward for future enhancements, things that we're thinking about for this use case would be specifying which fields would actually have specially protected information in it. So right now, the use case will say, we see a message coming through, does it have that protected information? It does, okay, it's gonna flag it. But an enhancement would be, we see the ADT coming through, it's got specially protected information. Wait a minute, I only wanna see ADTs from patients that have substance use disorders. And all of a sudden it's gonna flag those and maybe it'll push those to the top. You know, maybe certain facilities only wanna see certain patients that have, you know, suicide ideation or depression, or there's other pieces and components that you can do when you're specifying it. So what we're doing now is really the building block for that, and that will really just ramp up that care coordination down the road. And then another component is really the bed registry, which has been something that has been really important, especially with COVID and with just trying to figure out the availability in hospitals, but really it's utilizing the ADT for bed facility counts. So that would check the active care relationships for what participating organizations are included in it and then adjust the available bed count. I don't totally know the technical specificity of that at this point, but that's kind of the future vision of it. So that is really everything. I think that is my last, yes, that is my last slide. I know I went through all that information kind of fast, but we will do questions at the end. And then I'm going to go ahead and pass it on to Kim Batchelder to talk about e-consent.
Thank you, Crystal, and thanks to all of you for joining us today to learn more about the status of our e-consent product. The e-consent team is partnering, as Crystal said, with the ADP team on how to capture the consent needed to share, especially protected information ADT messages. Therefore, we're currently working on aligning the two projects and the use cases, since there is a dependency between the two use cases, as Crystal mentioned before. In the past, the e-consent team was working on a provider portal or a provider-facing tool that can electronically capture patient consent information. Since the tool is provider-facing, it is accessed through our My Gateway portal and was designed based on the state's standard behavioral health consent form, or also known as the MDHHS 5515 form. However, the team is working on enhancements to that portal that will make the user experience more streamlined and easy to use and being able to comprehend that information on the consent form. Because we know that, you know, we've heard patients could be in difficult situations or, in the office and may not be able to comprehend the language on the form. So we're trying to streamline that experience for the user to make it more easy for them. We also understand that there are other tools our stakeholders are using to collect consent related to sharing, especially protected information. Therefore, the team is working currently on enhancements on our use case to allow our e-consent service to collect what we're calling a minimum set of data from a third-party application. This will allow us to be interoperable with the systems and processes that our stakeholders already have in place. So basically, if you don't have a tool, we do have that portal tool. And if you do already have a tool, then we are designing or enhancing the use case to accommodate that as well. We are also, as Crystal mentioned, integrating our e-consent service with our ACRE service to create an ACRE's Choices linkage on a patient profile that indicates if a consent is active, the authority or location that holds the patient's consent, and authorized organizations or individuals the patient designated on that consent form. This integration of services will enable healthcare providers and patients to quickly determine when and with whom they can share specially protected health information. Next slide. Here you see, as I mentioned before, a sample of minimum data our team is using as a reference to define our file spec or standard associated with what kind of data we need to capture and create an ACRE's Choices linkage. We are utilizing the HL7 general consent model and the context parameters listed here as a reference in creating the standard. Again, capturing the set of data will allow our service to direct where a specially protected message or patient preferred delivery of certain types of data can be appropriately routed. Next slide, please. Here you see an example or examples of our active care relationship service. On the bottom, you'll see the ACRE's Choices circled. Our plan will utilize the data that we collect from our e-consent service to create an ACRE's Choices linkage. This will enable data routed through MiHIN, such as ADP messages that are tagged with specially protected information. Through the e-consent product, we will begin defining and collecting patient preferences to create an ACRE's Choices linkage. Our first step is to take the statewide standard, as I mentioned before, the statewide standard behavioral health consent form as our first example of a type of consent and create the use case around that minimum data set to create the linkage, but be flexible enough to utilize the same standard for other patient preferences, as you see here, such as advanced directives, portable medical orders, notification preferences, and other types of consent. Next slide, please. In our future phases of work, again, that was just kind of explaining our first phase and how we're partnering with our behavioral health specially protected information, ADP use case. But in our future phases of work, we will begin to explore how to enable the 4 types of consent directives you see here. So our first phase relates to the privacy consent directives category, and this includes capturing electronic consent for specially protected information as the 5515 form I just described. But in the realm of the privacy consent directives, we will also explore how, in future phases, how to integrate our services into patient-facing applications and shift the direction to patient-centric use cases where the patient has access to provide their preferences and establish their own designated care team. We will also integrate our consent management services into other types of care coordination use cases or services that are defined by our stakeholders or needs. Examples being consent to share social terms of health information that contains PHI or other types of stigmatized data that require consent. In later phases, we will begin to explore how to enable or incorporate research, medical treatment, and advanced care consent directives in our statewide e-consent service. Next slide. And that concludes, it was a kind of a brief update, but that includes our update on behavioral health ADP and e-consent products. Again, thank you for allowing us to provide an update to you today. Now I'd like to introduce Tracy Webb, our outreach manager, to facilitate the questions portion of our presentation.
Thank you, Kim, and thank you to all of our presenters this morning. We've had a couple of questions come in, although they have been answered in chat. No further questions have come in at this time. So Katrina, I don't know if you have any closing remarks or comments, but if other questions come up while you're going through those items, I will be sure to let you know.
Wonderful. Thank you so much to our presenters, and thank you, Tracy. Thank you all for the questions that we've received thus far. I do have a few announcements, so I'll get started on those, and feel free to, like Tracy said, input your questions in the chat, and we'll get to those after announcements. So MiHIN's newsletter, the interface, was emailed out yesterday. So just be sure to check your inbox for some great content related to our presentations today, as well as a message from our CEO, Tim Fletcher. We also have some exciting news about MiHIN's internship program. And if you have not already subscribed to receive the interface, you can do so by visiting www.mihin.org/the-interface. One article that I wanted to mention specifically in the interface is a data brief that we've reshared from the Office of the National Coordinator, and that investigates the rates of interoperability within U.S. cities. What's especially notable for us Michiganders is that Detroit is a leading U.S. city in interoperability, with all or nearly all hospitals participating in an HIE. It points out that cities with a larger proportion of hospitals engaging in interoperability have higher rates of providers with information available at the point of care. And that, of course, implies that these cities could be more prepared to make data-driven decisions in the event of a health crisis such as the pandemic we're currently facing. So for more information and details about how Detroit and other cities measure up, please look at the interface. And then lastly, I wanted to point out that the next scheduled download in January is being delayed by 1 week to allow us all some recovery time once we return from the holiday season in January. Generally, the download is held the first Tuesday of each month, but in January, it's going to be the second Tuesday, which lands on January 12th, and will be at our regular time of 11 a.m. We hope that you'll join us then. And as always, you can register for the download on our website at mihin.org/the-download. All right, so that wraps up my announcements. I just want to take a quick look at our chat and see if we had any incoming questions. Tracy, you want to take that over really quick?
Sure. We did have a couple more that have been answered within chat. Did have one last one come in, who at MiHIN is primary point of contact for organizations wanting to set up being a sender for ADTs. In general, you can always feel free to reach out to your regional account executive. That would be Chris Ford, Greg Kavanaugh, or Brian Bullock. And I will go ahead and drop their contact information into the chat as we wrap up here. They are regionally focused, so Chris covers the western portion of the state, Brian covers the center, and Greg covers the eastern portion of the state. So I'll go ahead and drop that contact information in the chat, and Katrina, we can just make a note to send that out to the group as follow-up as well.
Sure thing. And just from my knowledge, Forrest, I know you over at Midstate and you work with Matt Stromer. So Matt Stromer is going to be your go-to person as our corporate account executive for health or for our PIHPs. So you can reach out to Matt specifically.
Yeah, thank you, Katrina. That's all the questions that we have.
I think that wraps up. If anybody has additional questions, you can feel free to email me and I will get them routed to our subject matter expert at MiHIN. And with that, I want to thank everybody for attending today's download and wish you all a warm, safe, and very merry holiday season. Again, if you have any questions, feel free to reach out to me. If you have any suggestions for topics at future downloads, please feel free to make those suggestions as well. With that, I will say goodbye until next time. Thank you, everybody.